roadmap. We've heard about design. We've heard about information exchanges and collaboration to accomplish that. We've heard the view from Washington, D.C., and I did thank him for all the positive information he shared with us today. And we've seen a demonstration of exchanging data. So now we have our panel back together, and we're going to have Dr. Geraci moderate for us. So please welcome back to the stage Susan Kressly, Gregory Anderson, Ken Coburn, Camilla Hall-Brown, and Tracy Crawford.
Thank you. I was challenged to challenge the panel, and I'm going to get into that first in a second. But first, I want to challenge all of you. You heard me mention at the introduction to the talk that we just heard that one of our goals at the Medical Society is to look for innovation among physicians, driven by physicians. And I would like, if anyone can tell me about a doc that is extremely happy with their EHR. Susan, you're not allowed to say that. Extremely happy with their EHR and feels that it facilitates their workflow, makes their day go better, and makes them happy to be using it. Please let me know who they are. You're a group of people here who work in this field. Please let me know. One of the challenges that we have when I approach, my job here is to promote physician leadership. One of the challenges I have is that physicians are on the hamster wheel. Have you heard that before? That physicians really don't want to be involved. They just assume that you all, the vendors and technology folks, have it all worked out. And they don't want to hear about standards. They don't want to hear about stuff. And I'll tell you, as a recent victim of our healthcare system, I feel the same way. I went and I got a pre-op EKG, and I got it last Friday, and Thursday they called me up and they said, "Where's your EKG?" And I said, "I got it last Friday." And they said, "Well, we don't have it." I said, "Well, how am I supposed to have it?" And they said, "Where did you get it?" "Well, I got it at a facility that's in your network." "Oh, so we can look it up, right?" "Yeah, you might want to look it up. It's in your system." "Oh, there it is." But they called me to find out where my EKG was, pre-op. And then, of course, they turned around and said, "Oh, by the way, we know you got it a week ago, but it's abnormal. We're canceling your surgery." And I said, "My EKG's been abnormal for a long time, and you're not canceling my surgery. What do I need to do?" And they told me, and I got it resolved. But it did involve pulling some strings and getting literally a cardiology consult the same day. Try and pull that. Luckily, I have friends. So physicians are on the hamster wheel. Patients, as patients, we expect this information to be shared. We don't care about standards. I wanted that EKG to be done and read and okay for my surgery the next day. I didn't care how that happened. It should have been done. So let's just take a trip into dreamland, because this is something I encourage physicians to do. Step away from the hamster wheel for one moment and think about what does your practice look like in 5 or 10 years? There's a lot of physicians who say, "I'll be retired, I don't care." Okay, fine, you're retired. There's a lot of physicians in that middle ground, in the 35 to 45. They're not close enough to retirement to think about retirement or say that I'll be retired, but they're the ones that are on the hamster wheel. And I will say that the ones that are younger than that, like my son, the surgical resident, they say, "I want lifestyle, I want location, I don't care what my salary is as long as I make at least, what was it, $176,000 a year?" So to that middle group of physicians who really have their noses to the grindstone, feet on the hamster wheel, what does healthcare look like? Try to envision, what do you imagine? What does your ideal health system look like? So I'm going to turn to my panel at this point and say, all of the things that you were just discussing, and I'll start with Greg, All the things that you were discussing are in place. All the connections you're being challenged with now are in place. They're done. They're over. The standards were set. You're 5, 10 years into the future. What's next? What's the next challenge? What does it look like? And how will it work? And what do you see as your challenge beyond that? And if we could each take maybe 5 or 10 minutes to discuss that, I think we'll have an interesting start to our afternoon discussion. Okay?
So I don't need 5 minutes for that. Really, I think the least discussed aspect of what's coming with stage 2 and beyond a meaningful use that is going to revolutionize and transform, to use the vocabulary of today, is the patient engagement piece. I think people are right now, doctors are so focused on how does this affect me, Al Franken, that they're not thinking about the way in which they're going to have to completely recast the relationship they have with the patient and how the creation and maintenance of these records is going to occur on an ongoing basis. When I look at what it really says about patient engagement, about patients who are automatically getting reminders to be adherent to their medications, patients who are automatically, we discussed this morning, feeding back results of their scales because they're in obesity management, or are feeding daily glucometer measurements into a system where the doctor can see it. I think the patient more than ever is going to feel like a partner, and I think that's going to be a sea change in thinking for the doctor, because till now doctors have pretty much thought of themselves as being in control of the chart. It's their chart room, et cetera. The notion that somehow the patient is equally involved in that transaction, at one regard, is a little scary. I know all of you immediately go to the medical legal repercussions of having information in your systems that you didn't author, that you don't know how much responsibility you have for if it's ever discovered. That's our job as vendors, by the way, to make sure that that's very clear. So put that burden on us, because this is coming whether you like it or not. The new generation of patients coming up is expecting it. So I think the non-scary side of it is patients who are truly more engaged in their own health. And by being responsible for some of the management of their own records, reporting back to you regularly, engaged in regular conversations that occur outside the exam room, is ultimately a good thing in terms of people taking overall responsibility for their health and the recording of the information about their health care. So that's going to be a big change. I mean, we're already talking about, I'll give you one example, a boarding pass program where, you know, it's easy. The airports will figure this out, right? You know, you can walk up to any terminal in the airport, get today's boarding pass, you know, pay your luggage fees even if you need to. There's no reason why a patient carrying around a smartphone can't realize that they're in the vicinity of their doctor's office and have it already start checking them in. There's no reason they can't start the check-in process at home. And in Sue's case, I'll give you an example from Pediatrics. If you have a young child, there's a developmental survey you get asked every day. You've all been through it, right? Up till about the age of 5. Are they walking? Are they talking? How are they eating, et cetera? There's no reason you can't answer those questions in advance. And we've been talking about actually putting a fast track into exam rooms, that if you're willing to get your boarding pass before you show up in the office, you get fast tracked through the office too, to give the patient some incentives. But I think that's what you're going to see. I think that information everywhere it has gotten broader has democratized the experience. We've seen that in world politics. We've seen that in examples in this country. I think as patients get more access to their own information, they're going to take greater responsibility for and possession of it, and that's going to fundamentally change the way in which doctors and patients interact over the next decade.
Okay, I'm going to take your information and sit in front of my computer Lamborghini, and it's going to have like red, yellow, green sort of frameworks, taking all the information from the patient and the HIE and everything else, and new information that I can review that I haven't. It'll know what I already reviewed. It'll know what's new to me, so I don't have to look through it all. I'm going to look at this dashboard, and this kid's in the green zone for development, and the green zone for growth, and the green zone for immunizations, and the green zone for asthma management. And then I get to do what I get to do as a patient, which you can't replace me for, and that's lay my hands on the patient. And I can examine the patient and pick up something new that might not have been seen, and I can talk to the patient, which you still can't replace me for, and have a conversation about what's bothering them. In pediatrics, and that's where my experience lies, there is so much information that is gathered by having the time to have a conversation with the patient and the family. I want that time. Let you all automate the information, funnel it to me in a user-friendly way in some sort of dashboard, and then let me have a relationship with my patient. That's where I want to go.
You don't have any answer to that. I thought you were going to
Not
say,
that I can
I'll go back
publicly,
and
no.
build that right now. Interestingly, I had a similar experience with an abnormal EKG. Big difference for me was that I have a patient portal through my PCP, and I actually got an email notification that there was a result available and talked about to my PCP prior to any of that happening. So I'm at the stage, Greg, I mean, with my particular physician, that I have total access to my record, and I love it. But I realize that I am not necessarily the average person. And my 91-year-old mother would never in a million years dream of being given her lab results. But I do think the patient is truly where we're going in that patient engagement. And somehow, as an HIE, I need to help the physician also in how the data is presented. And I think that both analytics and decision support will play a huge role in the future, but I think we've got a way to go. And you talk about 2014. I'd like to know that 2014 we're going to make some big strides, but I think it's going to take a while to get where we need to go. But we have to keep trying, is how I feel. Even if it's not perfect yet, I'm hoping it wouldn't be as bad as some of the stuff that you showed. But we have to start somewhere, and I think that if you try to do too much too quickly, you're destined to fail. But I totally agree that the physicians become overwhelmed with what you're throwing at them if you're not doing some kind of decision support behind it and starting to help them see a red, green, yellow status. This needs my immediate attention. This I can come to later. So that's where I hope to be in 5 years.
Well, I can't say exactly where I hope to be, but what I see what's coming is globalization. We're so busy thinking about our own country and how we get our healthcare system to work that we're not realizing we don't have the time to think about all of the immigrants who are coming in and out of this country, and they're all part of the global economy. And then when they are from one part of the world and they expect a certain level of health care, and then they go work in another part, they're going to want to do the same thing. And then when these manufacturers who are working with suppliers and manufacturing all over Asia, and they do interoperability all the time. That's normal for them. They're going to be expecting that from our healthcare system, and they're going to be expecting it from everybody else. So I see that we're going to have a lot more exchange of people, a lot more exchange of healthcare. The benefit of this is all boats rise as everything gets better, but there are going to be some parts of the world that are going to be left out because they're not going to be part of the globalization and the industrialization of the global economy. So we're going to start facing new problems that we haven't had to really address yet. But I think globalization overall is a good thing.
It's a Yogi Bear quote about, it's difficult to make predictions, especially about the future. But the notion that Paul Lee was talking about the mega systems coming together, the 300 to 500, maybe. But right now, I still see we're likely to be in a period where the degree to which organizations can come together over common shared goals in service of the populations that they care for is still a really critical issue. If we can't get better at that, we're going to, the whole will be less than the sum of the parts of regional providers' assets. We'll be underutilizing that. The other thing is that I think those of us in the baby boom generation who fancy ourselves as so data hungry for our own data, wait until we have 3 or 4 competing chronic illnesses, and we're having a hard time sorting out which data is the right way to make priority decisions. I think we're going to want somebody, a person to talk to. I think that person to talk to often will be a physician, but I think the new team models that we're likely to evolve, it could likely be other people too that we're going to have as a trusting relationship to help us sort some of that stuff out.
Thank you for your interesting viewpoints. We have a bunch of brilliant people up here, and so I'm going to open it up to the group. You've been challenging all of our speakers today. Please continue. Any questions for our panel?
Thank you. It was very interesting the whole day. The model I'm seeing is changing. I think the whole model of healthcare is transforming, evolving, whatever you want to say. But, and it's been stimulated by the stimulus package, right? I mean, the monies coming in have helped us or fostered this innovation. But where do you guys see the sustainability coming from? I mean, what do you really see as being the driving force? I mean, if I look at high tech, what it means, health information technology for economic and clinical health, you know, we always seem to be focused on one or the other, but we don't really seem to pull them all together. I mean, you know, how do you see the HIEs and the data, the analytics, the new care models, the red, green, blue, or red, green, yellow, dashboards? What do you see as, sustaining the value these things are doing for you as opposed to just connecting data?
Surprise, I have something to say. First of all, I'm going to say here, and I've said it before in this forum, I get no high-tech dollars. Pediatricians, 50% of us will get no incentive monies from anyone from the government because we need to meet Medicaid thresholds in order to get any dollars. So I am not getting any dollar incentive to do anything that I'm doing it. I'm doing it because the return on the investment for me is there. I'm giving better quality care to my patients. I'm engaging them better. I'm making better clinical decisions with the information I have in there. And to me, the return on the investment of getting the information and the data is there for higher quality, and I have better satisfaction because I am able to spend more time at the bedside doing what I was trained to do. So there's my ROI, regardless of the money. And the data makes it easier for me to be more complete at what I do.
Let me say a few words on this. What I have to say is a little bit less uplifting. I've done this enough that I know that in the short term, I can walk into any community and I can find a return on investment for a hospital system, the physicians, and the health plans. And I know it can be done, and you know you can build, if you get your cost low enough, you can figure out how to make that health information exchange sustainable. But the long-term picture is our costs are way too high for the outcomes. That means there has to be a downsizing. It's going to come out of the pockets of the hospitals, the health plans, the physicians, the medical device companies, and the pharmaceutical companies, and maybe some others. It has to come out. So to me, there's going to be winners and losers. And somehow you have to figure out that you're going to be a winner, and what do you have to do to get to the other side before the other guy does? And that's so that you are sustainable in the new marketplace, which is value-driven rather than volume-driven. So it's going to be competitive, but you have to collaborate to be competitive to get to the other side. So it's a collaboration competition situation. Co-opetition, that's it. So is this good news or is this bad news? If you're in the game, it's good news. If you're lost, it's very bad news. That's how I would look at it.
I'd just also add, I think that, the experience in the Medicare coordinated care demonstration showed that of the 15 sites, our program, has been continued. And all the other 14 sites, because we huddled with them around what was different about the programs, and in addition to the emphasis I made on designing the model, many of them also, was less intensive, right? So the idea that we're going to get the ROI by making that assumption that you start by holding costs and you worry about affecting this later, I think that's going to really potentially hamstring us. If we don't occasionally provide enough sandboxes for innovation, say, you know what, just try to make this the best darn thing you can. And, that's what those of you in high tech, from my limited study of this is what most high tech fields do. They build the prototype first, and it's cost, $500,000 to create the prototype. You can't mass produce it. And then they figure out how to get it in a more cost-effective way to mass produce it. We don't do that. We start off assuming, if we make it too expensive, forget it. It's a no-go from the get-go. And we don't push ourselves to figure out how can we be more effective to get the ROI because we're getting better health outcomes. So we start kind of with our, restraining ourselves to be more innovative and more aggressive in our model. And then we wonder why we don't get spectacular ROIs, because we're doing kind of weak interventions, frankly. And we don't think, I think, aggressively enough about that.
Cam used the phrase earlier. I wrote a white paper for my company earlier this year about what we were going to do for stage 2, what we were going to focus on. And there were 3 things: patient engagement, interoperability, and value-based care. And United Healthcare estimates that in the next couple of years, more than half of their insureds are going to be in some kind of value-based program, not a fee-for-service style kind of program. So the doctors have to go along for that ride, and that's where they are going to get some of the value, because if you want to deliver value-based care, you need the information, you need to be managing the patient well, and it's become well nigh impossible to do it without having these kind of systems. That said, I will tell you, among people who are applying for high-tech dollars, particularly in the Medicaid side, we have some practices who take the first-year money and are not planning to submit for the remaining years for two reasons. Number one, they believe the reporting requirements are too burdensome and not worth the $8,500 they're going to get. Number two, they don't want to get too comfortable with that $8,500 because when it goes away in a couple of years, that gets to your sustainability question. What do I do when I become dependent on needing that money just to get through my year, just to maintain my practice? They'd rather not get started down that road knowing that it's going to disappear in a couple of years. They'd rather adapt to make it work without that money, and so they take kind of the front money to get themselves off the ground, but aren't even expecting to apply or to do the rest of the attestations that would be available to them. So that's, I think, from a practical level why the doctors are looking at this, because they can see the landscape shifting out from under them, and there's no way to really accomplish it effectively without having access to this kind of technology.
Now I'm going to challenge Cam, because I think when you start looking at the cost of healthcare, I think there's two pieces, one of which I can champion as a pediatrician. Preventative healthcare, we have to start looking at differently and put money and value there. We can't wait until it's a disease state. And the second piece, which people might throw tomatoes at me, is we need to have a social conversation about what is appropriate care at every decision point. We should not be giving expensive care because it's there and we are able to do it. We need to have a value conversation every single step of the way of should we intervene, should we start a medicine, should we do that, what is the cost, benefit, analysis, and risk, because I think that we're spending a lot of healthcare dollars for a small return on investment, but we can't all have this conversation. This has to be a national conversation on a social level that most people have been very shy to engage in, but I don't think we affect cost until that happens.
Hi, Dave Grinberg from the Pennsylvania eHealth Collaborative. Agreeing with what you say about needing that national dialogue about evidence-based medicine. Also need to look at figuring out differential costs associated with lifestyle choices, associated with choices about preventive care, all that kind of thing. But we have EMR vendors. We have hospital systems. We have state HIE initiatives. We have regional HIEs. Some states have utility-based models where the state's doing it. Some states, like Pennsylvania, have collections of HIEs that are theoretically figuring out the functionality between them and the provider. And then what we're doing at the state level is figuring out the functionality between the HIEs. You have ancillary software vendors out there building claim systems for insurers that are trying to manage, trying to go toward patient-centered medical home, that kind of thing. You have all these different people working on 100 different ways to improve information exchange as a way of driving forward care. And how good a job, from your perceptions, do you think we're actually being effective with coordination among these various entities, or do you think are we successfully moving the conversation forward with all of these competing entities working more or less independently in 100 different environments?
So I would say this: it doesn't matter how many people are writing books as long as everybody can read and write English, which is what standards and interoperability are about. And that's what's missing right now. That's the reason I can't easily interchange records with other systems, because there wasn't agreement upon what language and what grammar we'd be using to have that conversation. So there's room for a certain amount of that. There is, like any other new market, it has probably attracted a few too many people, and they're probably going to winnow away. I predicted in that paper I just described that I believe a third of all people currently certified are not going to make it to stage 2. I think the requirements are that much more rigorous, and that there's any number of companies that don't have the technological wherewithal to make it through the entire, and I think that's intentional, by the way. I think way too many people got certified. There's way too many people in the conversation. But you need a few of everything, you know, and even there's different specialties. Even within the HIE community, there's different approaches to things based upon political differences between states and how they'd like to accommodate these record exchanges. And so it's not a bad thing for there to be that competition out there as long as everybody's having the conversation around the same central set of standards, which is what really has hampered the efforts up to this point.
So I'm going to translate this to the IIS world. IISs came into favor 15, 20 years ago, and there were a lot of hamster building, a lot of different states, a lot of different places. It's finally coalesced into a place where having meaningful use and exchange of data that is affecting point of care decisions. So I think there's a little bit of churn that needs to happen at the beginning until people figure it out. And, you know, we all know that as soon as you write the technology, it changes. So it's just taking off in such a fast pace that it is a little disconcerting to watch a lot of silos. You know, some days I want to go live in Delaware where it's a small contained state and you can stand there and, you know, be king and say this is how we're doing it. But we are in a complex environment in Pennsylvania. Being right outside of Philly, I absolutely can tell you. And but it doesn't mean that we shouldn't be doing it. It means that we should be doing it, but we should use platforms like this where innovative people can hear pieces of the conversation so we can sort of funnel it in the right direction. And I think eventually, you know, my Taj Mahal will get built.
There have been a couple of black holes that have been mentioned but sort of stepped over. So one of them is health behaviors, which is patient engagement related and patient adherence and so forth. And the other one is behavioral health, which is a complicating factor in most complex chronic disease conditions. And these are areas where the privacy and confidentiality is also a confounding kind of point. So in any of these improvement models or anything like that, where does impacting those areas of health come into play with regard to the exchange of health information?
So that's a hot topic at the Medical Society because it used to be the data, when you give a physician a bad report, the data are wrong, it's not right, et cetera, et cetera. Now it's my patients are less compliant. So I think the issue of patient adherence, patient compliance, not the right term, is going to be, I think, one of the major future issues. And I think part of it comes to the conversation that Dr. Kressly alluded to, and that is we have to have a social conversation. So if you smoke, do you get charged more? How about if you're obese? How about if you practice karate with 14-year-olds and hurt your shoulder? Where does that line of behavior get drawn as to inappropriate?
Question. We spent a lot of time trying to think about that, and from my days doing HIV/AIDS work, I'm thoroughly convinced as a clinician that, with very, very, very rare exception, nobody goes out of their way to disadvantage their own health and well-being. But our system often doesn't understand the perceptions and perspectives people have that keep them from being able to be more effective in advocating for their own health and well-being. So our nurses spend a lot of time trying to understand that and trying to start from where patients are in terms of their perceptions of needs and preferences and competing priorities. And I'll tell you, in the older chronically ill population, the feedback that we're collecting from patients that our nurses are gathering when you do cognitive screening on a very consistent, close monitoring basis in terms of deterioration of cognitive function, when you do depression screening, when you do abuse, violence, and neglect in the home, domestic violence in the home and the elderly. I mean, I am sure our national statistics are way under representing what's really going on for folks And so I think a lot of those behavioral health behaviors is going to be an important area of support and continued resource development. There's not enough, at least in the older population, geropsych support in most communities that we're in the 4 counties. It's a tremendously unmet need, and I think the need is underappreciated because our data is not as good as it would be if we had engagement systems to surface it. And the docs that we work with collaboratively have been great about understanding and being supportive of working with the nurses when it gets surfaced, but patients often go into their doc's office and don't talk about this stuff. So it's a complicated problem, but I think we need to get closer to where people are living and understand how they're living and what they need.
We just finished our NCQA certification, and just a caveat on the behavioral health aspect of it, I would be interested to hear there is an explosion of telemedicine, telepsych. Well, telepsych's been around for a while, but now it's teleheadache, telesleep, telederm. How do you see the telemedicine fitting into this picture? Because it is regulatory, they're looking at, especially for behavioral health. I'm just wondering how that all fits into this exchange.
Well, the time for the virtual visit is here. From my standpoint, parents don't want to leave work if they don't have to. They want to be able to do things virtually. And there are a lot of pilot projects where there's set up a medical enabler or assistant at a daycare that can get on and do Skyping or look in an ear, and you could see it. So I think that's there. We need to figure out a way to somehow not give that care for free. And, if you start looking at outcome-based and patient satisfaction, we would have already been there. The problem is that the burden of the payment comes currently to the physician, and we don't, especially in the primary care model, we don't have the profit margin to be able to support it. But I do believe that all of that virtual encounters, whether they be telemedicine, I would still argue, and again, as an NCQA level 3 medical home, that belongs to be managed in the primary care setting in the medical home. And the one thing the medical home teaches you, and Ken will adjust to this, it's not about the physician, it's about a healthcare team. This all doesn't have to be driven by the physician, but I do believe virtual health and remote, and that's going to help some of our colleagues in Wyoming who don't have access to the specialists they need. So I do believe that's part of it. I think it's going to be creative in how do you capture that from an EHR vendor, and then as an HIE, how do you distribute that information that's captured there? I think it's totally doable. We just need to get creative about how we make that all happen.
I've got one for you here, and maybe you can help me with this. We heard today that you're going to see significant consolidation, which most likely will create bigger organizations, and bigger isn't always better. But given that that's the trend, then what impact will that have on continuity care and on the quality of care as delivered to the patient, and possibly rationing in the future?
So I'm still going to be independent till I retire in 15 years. But I would argue that one of the things that the medical home concept does, which is where I believe that we really should live, is that although you can be part of a bigger healthcare system with supported ancillary, there's one point of contact for the patient, and that's the person or team that leads that. So while there may be huge health systems, there will still be, this is my primary care team, which I use for point of care. And whether you do that as part of a big health system, but the patient identifies with their team and doesn't know who the rest of the people are, but they have, if you will, a shepherd to shepherd them through the healthcare system, whether it is in their integrated model of a larger system or in a fragmented one where your nurse takes you to your doctors and specialists office. I don't know that that matters. I think long as we keep a patient focus at the center of a medical home, it doesn't matter. Now, I would argue that some of us who are smaller are nimble, more flexible, and can do it cheaper and easier because we can innovate much faster. I mean, it doesn't take a board meeting for me to decide that we need to figure out a way to reach out to our asthmatics. We have a lunch discussion and make it happen. So so I would argue there's still value for a small, but that can happen whether you have a team that's, if we build this in a way that's smart, you'll still give room for flexibility and innovation in the team that's caring for a subset of patients with the support of a bigger network and population health management and evidence-based guidelines.
Corollary to what you're saying, 'cause I definitely see the dilemma. For financial reasons, there's probably going to be consolidation, but with that comes bureaucracy and a lack of understanding of what really needs to happen at the clinical care level. So somehow people have got to figure out how to design organizations that have the resources that get down to where the work is actually being done. And there's a massive change management issue. And if you're watching some of the mergers that have already occurred over the last couple of years, many of them are struggling because they buy an organization or merge with another organization that had the culture just right, and then they change the culture and they can't deliver what they were delivering before. So I think we're going to see a lot of that. And it's going to be 10 years of continuous change management.
There hasn't been much talk about social networking today. I would have to be the one to bring it up, but maybe the Facebook IPO has us in a fog about that. I don't know, but and I know Gus tweets, so we've shared a lot of those. But back to your point about the patient engagement being so important, how do you see social networking playing into that and being a benefit to make that happen sooner or later?
Well, yeah, well, I could.
Nobody will.
No, I that's one of those I could tell you, but I'd have to kill everyone in the room questions. That is absolutely, particularly for us as a pediatric vendor, where the entire population of people bringing young children to the office is part of that connected generation. At the top of our list, we're hearing it already very frequently, and the patient engagement experience is absolutely going to be driven by social media in the next generation. So.
And he's already building to mobile apps, to smartphone, to Android, to portal. I could give you portal stories of patients who were at the point of care accessing it.
But the truth of the matter is, I mean, to give you a very simple practical example that happens in Sue's practice all the time, once a month, everyone who's about to have a baby at a certain point in the pregnancy comes in and has a little prenatal visit with her. You know, that often starts lifetime friendships among the parents who are all having kids around the same time, or at least they communicate with each other afterwards because they tend to have kids at the same stage of life with the same problems, and they get together. There are ample opportunities for people organized around either common medical care or common medical concerns to interact socially. Obviously, there is a delicate issue associated with HIPAA in terms of the degree to which information is revealed, but if I've learned one thing, and I've got two daughters in their mid-20s right now, this generation doesn't know what HIPAA is and doesn't care because they put everything on Facebook, right? I mean, they don't understand the issue of privacy because they don't seem to experience personal privacy. It's really alarming. And my daughter, who is a trainer for our company, expressed the other day, because we were talking about some of what we're thinking about doing, she said, you know, sometimes it frightens me with my friends how much they put on their Facebook about their kids, because she's at that age a few years out of college where some of her old college friends are starting to have children themselves. And she's like, can't they give those kids some privacy? Don't those parents understand that that's going to be there forever? And when that kid is a teenager, they're going to, be exposed at that point if you look far enough back in the parents' timelines. So I think there are still some lingering concerns about that, but I absolutely believe when you start talking about patient adherence and things like that, and that level of patient engagement, that doing it through that sort of process is going to be a key element of delivering it in the way that those people want to receive it.
Hi. You've touched on a couple of things when you mentioned preventive care, and Ken, you're talking about meeting patients where they are and addressing some of those other issues that don't always get revealed, but obviously play out. Can you all talk about what you see as the relationship between medical care and social services, and particularly those community resource organizations, and how you'd like to see that evolve?
Partnerships. Medical care should not and cannot be delivered in a vacuum. And there is a social impact. And in medicine, we've gotten so good at preventing infections. Just how long have I been doing this? 20 plus years. my patient panel and what I take care of them for has totally changed. I no longer am admitting kids for meningitis and problems related to serious infections. I'm having anxiety, depression, and those things, and I am not well equipped to do that by myself. So I don't know where we involve it, and when you start talking about data exchange, we got to figure this out, guys. We can't just carve mental health out and say, or adolescent privacy and say it's too hard, we'll get to it completely later. We got to let these folks in on the bus and find a way to make it happen.
I've given a lot of thought about this over the years because I used to do human services consulting. And in the old days, they called that wraparound services. And to have education and medical care and human services separate doesn't make one bit of sense to the human services industry. They've always integrated those pieces. And they've always looked at the whole family. A girl comes in pregnant to the emergency department. She's a presenting problem, and they immediately start to look at, is there anybody at home who needs a job? And how is she going to get to the medical center? And are there little kids that are having trouble at school? And they start dealing with the whole family. It is an entire family system. And I've sort of been waiting for the medical community to start to realize they need to be part of this bigger system that is already existing, that the human services know. And you find little pockets of that, like in Dayton, Ohio, they have a database, and it's organized three ways. It's organized by clinical care. For the educational system, it's organized by student, and for the human services system, it's organized by family, because that's how they do the Medicaid and the food stamps and all of that. And so serious integration of care has got to get those three systems and recognize that they are different systems, and we have to figure out how to get them to work together. Now, the human services tends to be a buddy knows buddy, and you make the call to your friend, and so it falls apart. You're nodding your head. That falls apart when somebody quits their job, and the medical system is a little more stable in that regard.
And I'm going to make a comment on that subject as well. And I think part of the, what goes around comes around. A few years ago, we tried to do, physician organizations, and they fell apart really because we didn't have data. We thought we could just do a better job than the insurance company did, but there was no data. And I think the evolution of the medical home concept is that the data and HIE are going to come together. And we think of providers as nurses and doctors, but I think the definition of that has to expand, and it has to include social services. It has to include behavioral health. It has to include all of those. And they all have to have access to the HIE. And once that happens, I can remember, as little as 2 or 3 years ago, the big thing was co-location. You need to be you don't need to be at the same site. The patient doesn't even need to be at the same place. You all just need to be able to communicate. And I think for this group, HIE is where it's at. If everyone can share a common database and see what they need to see, then that solves all of that problem.
Yes, this is a question that's very parallel to that, in that I'm playing off of what Dr. Coburn talked about relative to system design, and we know what the system design of health information exchange, the design factors are in a health information exchange. Most of the conversations that I've been involved in the last 4 years within organizations define clinicians, generally talk about clinician stakeholders as physicians. And physicians would be, I know, just wait a minute, I'm telling you, I'm sitting here, so physicians would be defined as MDs, DOs, hospital affiliated. Let's just take that, okay? Let's just say that's how I perceive the conversation over 4 years, In Pennsylvania, we have thousands of non-MD, DO, non-hospital affiliated clinicians, which translates into hundreds of thousands of patient records. So how are the non-MD, DO, hospital affiliated clinicians going to be assimilated into the health information exchange? Is it going to be the same pathway, same system design as the MD, DO, hospital affiliated clinician? And a good answer is yes.
Well, you and I have known each other a long time, Charlie, so I'll answer that, and my answer is yes, because clearly, part of the problem is that the data right now is completely siloed. And so, if I go see my optometrist for my contact lenses, because ophthalmologists are too expensive and I don't need their skills for that, my family doc doesn't know that. He has no record of it. He doesn't know that the optometrist looked in my eyes and did a retinal exam, and that's not reflected in my record. And then he says to me, "Have you had a dilated eye exam?" And I say, "Yes." And he said, "Well, I need to get that. That would be nice, so that you can document that I had that because I'm of a certain age." But that kind of stuff has to happen. And there are lots of stakeholders in the system that are not generally being talked about, and I think need to be included in the conversation. Down to the part of the conversation now is about community representatives. You take a kid out of high school, you take a kid in high school, and you say, "Hey, who at home could benefit from a little nutrition education?" You teach the kid about nutrition. They go home and teach their siblings and their parents about it, and then they serve as mentors to kids that are younger than them in the school. That's a primary care physician doesn't have to do that anymore. It's really a waste of our time, because we need to use what we're trained to do, not provide basic nutrition education. Ken?
I think it's a great question. I think the answer is yes, but I think it's going to pose some really challenging issues. I know some of my physician colleagues who take their work very seriously for patients are going to raise a question of like, well, if all these other folks are inputting all this other data, and I'm already overwhelmed with all the data I'm getting, is it I who am expected to be able to review all of this stuff? Or are you going to create systems where I'm intelligently flagged when and if something from those other providers merits my attention? And so this issue of how we distribute, Atul Gawande talks about going from the period of docs being cowboys to being members of pit crews. That's how he describes this idea of moving to team-based care. But it's a journey that we haven't really designed or mapped out very well. So the answer should be yes, more people should be contributing to that understanding of a patient's needs. But how that gets distributed and whose responsibility it is for making sure that that's all being attended to, I think still has to be worked out and designed.
The one other comment I'd make towards that is I've been fortunate enough to work at the Children's Institute. We actually have three components: rehabilitation, a school, as well as a social service arm. And I think one of the other challenges is at the vendor level to have people at the vendor be able to understand those different kind of components, because we struggled to actually even select a system because we had to describe that. We can't buy a separate system for each of those different components, and there's no need to buy a separate system. You just need to understand how to collect and how to arrange the assessments and the data to be able to get that information out. So I agree with the folks. It's like we're not there yet, just like Tracy said, but we're not giving up yet either. So if we keep that moving, we're going to get there someday.
One more question.
Yes, thanks. By the way, you just need the right HIE vendor, because that stuff's available. Dr. Kressly, I just wanted to confirm, because I keyed off one thing when you mentioned that, I think it's a great insight, when you said that in the patient-centered medical home, it's not just the doctor, it's the care team. And was I also correct in understanding that the workflows, the designs that you've done in implementing that has been kind of from the ground up, very organic development? Could you describe that, how you develop the workflows to coordinate your team? Be very, then Dr. Coburn, to put you on the spot after that, from the design perspective, are we on target with what Dr. Kressly might say?
Can I be excused?
No, I almost killed him for the NCQA process because he had to help me make the application. But the reality is I left a big group practice after 15 years of medicine with an idea in my head of how I wanted to deliver care to families, partner with them using technology, long before I really thought I would end up where I am now. But But part of the process was sort of coming up through workflow. And then NCQA's formalization process for medical home made me really actually articulate and put into words and documents and policies and procedures. So if I die tomorrow, someone else can still see my vision, my staff's vision. But it made us really go through the process of sitting down with my whole staff engaged on, we talk about things as simple as, where are the bottlenecks? Why are people sitting in the waiting room? Whose problem is that, and how can we collectively fix that? And so it came with NCQA's guidance of what they saw, coupled with my vision as what I wanted to do to create a medical home for my families long before that process. And I think it was the marriage of sort of my wish and my vision with their sort of tenets to sort of put into policies and procedures that got us to where we are. And the thing you learn about NCQA, and this is, so here's my plug for this is where HIEs are. This is a process and a journey, not a destination. We will never arrive at the Taj Mahal. It will just change, and we all have to get into this continuous quality improvement. How are we doing? What worked? What didn't? Where are the pilots that worked that we should make bigger? Which are the ones that we should say, nice try, but how can we learn and start something different? This is a process, which as physicians in traditional medicine, we're not good at. Let's get the paper form and use it for 20 years. That's gone. We just have to start thinking about always, always, always changing, improving, innovating, looking reflectively of what we've done, using data, not just a gut feeling about how we're doing to improve and for the next iteration.
I'm glad for the question, because one thing I wanted to emphasize is that I think that the work that's happening in what would be considered microsystems, office units, trauma teams, ICU teams in hospitals, all that work of improvement for safety, reliability, better patient care, quality is absolutely essential, and we need to continue to ramp that up. The efforts to do that need to go on. I think the trap is to make believe that if we do that really spectacularly well, that in and of itself will fix our larger health system delivery problems. I think that we need all those micro systems to be working really great, but then we have all the big gaps in between in the continuity of care and the long-term care issues with chronic disease. And so I think the design issues then challenge us to figure out how to do those things better. But it's not an either or. It's not as if we should, the kind of stuff that I was talking about longitudinal care and community-based teams supplants the, tough work in each office visit to office practice to do a great job with what they need to do. I think that has to run simultaneous and in parallel.
Just to amplify one of Sue's comments, as a company, we've now had a couple dozen of our practices go through the whole patient-centered medical home journey. And I would say to a practice, they have all come out of it saying, we thought we were doing a really great job. Turns out we really had some room for improvement when we sat down and had a look at it. Not just in terms of policies and procedures, but in terms of follow-through on things. And in Sue's practice, the biggest weakness turned out to be referrals. Even though our software for years had the ability to put a referral in, track it, whatever, they just weren't doing it. And as part of getting involved in medical home, they named somebody to be the referrals coordinator. And they went to the screen religiously every week and said, whose flag date has come up, but we haven't heard a report back from the specialist in the time we would have expected to. That person's job now is to follow up on that. One of the outcomes of that, in terms of improved quality of healthcare delivery, is there are certain large organizations in the Philadelphia area who shall remain nameless who turn out to be especially bad at returning specialist reports. And now that's been identified, and some of the people in those organizations have been threatened that if you'd like to see any more of my patients, encouraged to improve the pace at which they return their referral reports, against the penalty of, I'm not sending you any more referrals because you are killing my medical home scores, because I can't document I'm getting referrals back on a timely basis from you. So that really has turned around and engaged in an entire process of improvement throughout the system and all the coordination of care with some of Sue's patients. So that's a good example of where her having taken that one initiative has fed back through the entire system in a really meaningful way.
They want to be part of my medical home neighborhood. They have to play with me nicely in the sandbox.
Well, I'd really like to thank all of our panelists and speakers today. This has been awesome. Thank you very much, and I think we have a break. So if everyone wants to come back at 3 o'clock, I think we'll be good. Oh, we could have our speakers come over here.